Welcome to MedHeads, the weekly show that brings a biopsychosocial focus to issues of the day, along with special guests who will showcase their expertise and enthusiasm about their field of practice. Your host, Dr. Fergal Armstrong.
Hello and welcome to this episode of MedHeads. My name is Dr. Fergal Armstrong, and today we have with us on the show Maree Eisma, a mental health social worker. Hello Maree, how are you?
Hello, how you doing?
I'm good. So Maree, I thought today we'd talk about the difference between group therapy and individual therapy as it is applied in alcohol and drug treatment. What is group therapy? What's individual therapy? What's group therapy, first of all?
So group therapy is essentially where people come together, usually with a common cause. There's something that might bring people together. So it could be, I've certainly seen group therapy from everything from obviously like things like your 12-step programs, to behaviour change, to support groups for people who might not be using drugs but might have family members who are affected. People who've experienced trauma. I've seen guys groups do amazing for sexual assault, for victims and survivors. Same with girls groups. But essentially what happens is people come together. Usually there's anywhere from 6 to sometimes 12 participants. Anything beyond that can get a little bit hard to kind of, from a person who's watching over and kind of convening a group, it can be hard to just keep an eye on what everyone's up to. So essentially, some of them can be time-limited groups. Sometimes they can be closed groups. So people get together and they start at a certain time and they follow through for a number of weeks. Other times groups are open, so people can just come and go as they so please.
It must be very frightening for someone who's thinking about their recovery to think, all right, okay, I've got to go into a room, not know anyone, and then sit down, and then I think I've got to tell my story when I don't even know what my story is. What do you say to that?
Look, I think my understand, certainly with groups, and the feedback's certainly been given to me from clients, is that if someone's sort of overseeing a group well, then they will give permission to participants to share as much or as little as they so choose. I think, anyone who does any sort of good group facilitation would understand that, starting off into a new group is going to often feel quite unsettling. People have got no idea. And you're right, people don't know what their story is. I've heard lots of mixed stories about group work. I've heard some people in their journey of changing their relationship to substances, where some of the 12-step programs have been absolutely brilliant for them. Then I've seen other people have come to the other side where they're like they can't keep being immersed in people's the sadness. Some people have, it's got to a point for them where they can't sit there and be exposed continually to perhaps some of the adversity of substance abuse. For them, they've had to then go off and do some of their own individual work because it's just too, it's not relatable to them anymore in where their world is. They've moved beyond it.
So it's
so
not
everyone's got, I think, yeah.
It's not inevitable that everyone will benefit from group work all the time. It's something one has to decide
absolutely
the right time for.
Totally. And some people, group work is just not a good fit. If people who are majorly psychotic shouldn't be cruising around in a group. There's certain personality styles. If some people have got like considerable, antisocial personality traits, if someone's incredibly narcissistic, even with people who have got, incredible social anxiety, sometimes a group is just not the right fit for such people.
Yeah. So it's not as if group work is for everyone.
Absolutely not. No. Some people, it's not a good fit. And if they're willing to perhaps maybe do some of their own individual work, group work might be a nice thing to be added on, but it certainly wouldn't be, your first line of launching in for sort of help, in my personal opinion anyway, especially for those categories that I've just mentioned then.
And you've got to be finishing a withdrawal program. You can't go through withdrawal at the same time as engaging productively in group work. So there's also a timing issue as well, isn't there? So
yeah,
you mentioned,
and I think,
sorry, go on.
No. I was just going to say that, sometimes, like for some of the, like your 12-step programs, people may not necessarily be completely, they still might be using, or they still might be, using a few times a week. Whereas your more structured, probably group work where it's like relapse prevention, maybe a requirement of that is that somebody's not using, and their common bringing together is around skills of, not falling back, or, not relapsing, or, it might even be like a CBT group. It could be something around understanding cognitions and the impact of cognitions that they have on our behaviors and stuff.
So you're throwing to me a lot of words that are very triggering for me. So you've mentioned 12 steps, you've mentioned CBT, you mentioned families. I mean, what I'm trying to think of is an overarching classification of the groups that can occur. So I suppose in my mind, I have a list of groups can occur in the following schema. So 1 would be psychoeducation, 2 would be relapse prevention, 3 would be CBT, 4 would be family therapy, and then the 5th one in my classification would be peer support groups, including 12-step programs and also smart recovery. So these are terms that a lot of people may not have heard of. Could you tell me a little bit about what your understanding is of each of those?
Yeah, so, a lot of the 12-step programs, you can have one that's specific for a person who's actually using substances, and you can also have another one for the families who are affected, because, what we know about substance abuse is that the substance actually becomes like the prime actor on the stage, and everyone's behavior is tweaked around. So for the person who's using substance, their goal is, they will tend to prioritize access to that substance or substances over anything else. That's just their focus. But then, of course, when we've got people who are family members connected with that, their focus then becomes on managing the substance. So there's often an aspect of control around that. But I guess when we really peel everything back, the cornerstone is the substance, and how that's impacting. So, that's usually one of the focal points. So when they've got the 12-step program, you've also got one that parallels, which is for family members who may not be using. So yeah, you've got your peer support stuff. You've got some that, some people don't like the 12-step concepts. They don't like the idea of,
why would that be?
surrender. Some people, because the format, as I said, sometimes people, look, I think the other thing that comes up with group work is the confidentiality is, even though it's spoken about as part of a connection of people coming together, there is a huge amount of trust in knowing that you're sharing your story to potentially 12. And I mean, sometimes those 12-step groups have much more than just 12 people. They could have like quite a few people. So for some people that's not, they don't feel safe. They don't feel that their information is going to be protected or honoured. So that can be another thing that can be a pivoting point for some people. But yeah, you've got your CBT group. So you've got, they might be a more structured group where it could be a specific 6 to 10 weeks. It could be looking at the different, core beliefs that trip people over that could then lead to somebody using, some of the things that kind of the cognitions that keep people stuck in repeated patterns, and things like that. So, and when it comes to the family stuff as well, as I said, that's, some of them can be specifically 12-step focused. Sometimes they can be just more of a peer support model. Other group supports could be things like anxiety recovery, or for people come together with anxiety conditions. So, there's certainly scope for lots of different ones out there.
So what is the difference between a 12-step program and smart recovery? So they're both programs that are effectively peer-based, aren't they? but there is a key difference. How would you describe that key difference?
My understanding is the 12-step model is very much based on a disease model, that people have a disease, and that for a lot of them, there is that surrendering to something bigger than themselves. There is more of a
power concept.
The higher power concept. Now, some people, that derives a lot of, for some people, there's a certain. It takes me back to the work of a psychiatrist, Dr. Michael Carr-Gregg, who wrote about one of the biggest things that a lot of adolescents are, why a lot of people, adolescents, are struggling with mental health, is that they're actually what he refers to as spiritually anorexic. And I know that even when I was doing some work on, back in my years and years ago, a study, Durkheim's typology of suicide, and we were talking about the importance of having a connection to something bigger than us, and how that is important. But for some people, that concept of a 12-step program, that concept of a higher power, is like it's something that they just can't get their head around. They're not interested in it, or they make the link and think it's becoming a very like a religious-based thing, and some people run a mile from that. Has that been your experience?
Yeah, it's for this concept of the higher power either is very enabling or is very disenfranchising, and it's entirely an individual thing. For some people it works, for others it just doesn't work. So it is what it is, and for those people for whom the concept of the higher power is disenfranchising, I always say, well, look, there's always smart recovery. What would you say about that?
Exactly. Look, I think it's a beautiful option. I think it's a really, really nice option for people to have that, and look, sometimes, it's like you walk into a shoe shop. You don't just plonk your feet in the first shoe and run and pay for it. Sometimes it's about, the fit. Sometimes it's about what does it feel like. And sometimes it's about giving people permission to try something different. If this doesn't work, perhaps try this.
Yeah.
So
there's also the concept. There's also the issue of, do you have to be abstinent of pharmacotherapy to actually engage in some of these groups? Because I think in the past, certainly with the 12-step programs, it was felt that you weren't properly part of the group, or you weren't properly engaged in your recovery if you were still on pharmacotherapy. But I don't think that's such an issue anymore.
No, I had the same thing. I had a client having a terrible dilemma because they were taking an antidepressant, and they're like, well, I'm not really completely free. And I'm like, oh, well, it's what you're weighing up the pros and cons. I mean, if he wasn't on his antidepressant, he wouldn't have been able to get out of bed to even get to the group to begin with. So it's very much horses for courses. Yeah.
So one has to be mindful when one is seeking a peer support group to engage in, that, are you going to benefit from the concept of the higher power, and is your group going to facilitate your continued use of pharmacotherapeutic interventions as recommended by your treating physicians?
Absolutely.
Tell me about your views on psychoeducation and the value of psychoeducation within group work. I mean, what's the point? What's the point of telling people about
Look, I personally, and I do this with my individual work, but psychoeducation is, to me, it's foundational. If people cannot have an understanding of perhaps what's going on brain-wise, physiology-wise, socially, like when you break down the different sort of pillars and then you help educate clients on that, you can see I don't know, for me, there's a relief, oh my gosh, that's what's happening. And when people can make sense of what's actually going on from the education that's happening, I think people can then just build on from that. But I think without a very good basis, meaning the actual understanding from a psychoeducation perspective, for one, I think it also introduces language. I think it invites a common language that we then just use with a shared meaning, and it builds on from there. So without psychoeducation, I think that's usually, whenever I'm doing any work with clients, the psychoeducation is usually first and second session stuff anyway, just so people have an understanding of what's happening. Without it, it's like you don't have a map. There's no GPS.
So really what you're saying is it provides people with the tools and the vocabulary to consider and engage in their recovery.
Absolutely. Yeah, totally.
Yeah. And then we've talked a bit about CBT. I suppose there are two main talking therapies which I consider to be very appropriate for AOD. One of them is CBT, the other one is mindfulness. What is CBT? How would you describe CBT?
So CBT is essentially looking at the cognitions that we have. So, sometimes, a person may have a very, very strong belief, and a lot of this links in with sort of schema therapy, which essentially means that, we've got these schemas that we've formed when we were younger, and they almost become a lens in which we see our world through. And essentially, people will interpret their world through these glasses that could be quite limiting. So a lot of the cognitive stuff, we can have things like, your black and white thinking. So people either believe that they're this or they're that, but there's no shades of grey. They were either fantastic when they did that presentation or they were totally terrible. Or, the generalization. So believing that, people can get caught up into very, generalized thinking,
Like
all
what?
or nothing thinking. As in far as
Can you give me some examples
generalisation?
of this? Yeah, so generalized thinking, all or nothing thinking. What would be examples of that?
Yeah. Okay, so generalise is coming from the word generalising. So sort of assuming that just because, one person thinks a certain way, that the whole population's going to think like that, which may not be the case. We know that there's so many variances in how people make sense of their world. So the black and white thinking, or the all or nothing thinking is essentially where, it's absolute. There's no capacity for, an alternative perspective. So, and this is where we can get caught up in a lot of biases and a lot of, we might make assumptions about certain races, or we might make certain assumptions about, someone goes to a gym and they don't, they don't do 20 pull-ups or chin-ups. All of a sudden, I didn't do 20, therefore I'm crap. I'm not good. Right. Those sorts of, extremes is probably, and they can be very, and a classic in substance abuse is, well, if I've had one beer, well, I've broken my quota and what I said I was going to take. So therefore I might as well drink the 6-pack. So you can see how people trip themselves over by these beliefs, and like an example I give to my clients is,
there used to be a saying in Ireland, you may as well be hung for a sheep as a lamb.
Yeah, exactly. Yeah. But yet, like,
you may as well have one, you may as well have a 6-pack.
Yeah, exactly. And a lot of clients will do that. They're like, I'm useless, and then they'll buy into the story, and then they'll go off. But like an example sometimes we use, and I don't know, you've used it or are aware of it, is that thing that, if we have a flat tire, we don't then go off and slash our other 3 tires. Why would we do that? But when you're really caught up in that cycle of the believing, people, it becomes so sneaky in how it happens. And a lot of people honestly don't believe, like, and the poisoned parrot, that's a beautiful concept where, the poisoned parrot is the one that just jabbers away on the shoulder of someone, telling them that they're useless, telling them they can't do anything right. Or why don't you just go and use? Why don't you just go and get drunk, or whatever other story might be going on? So yeah, that's sort of more around your CBT. So it's sort of looking at how your thoughts impact, like a situation happens, your thinking is involved in that, and then there is a resultant behavior. Yes. So whereas your mindfulness and sort of acceptance and commitment therapy, which are the two that I tend to also use, is more around, the way I explain it to clients is cognitive behavioral work tends to look at the cognitions. So we might be going in like a scientist or a social scientist would, by going, okay, so if we're just curious about what's happening and we're, if the belief is this, where would we look for proof that perhaps that's not the case? So one of the things when I trained in mindfulness was that it looked at, I sometimes see CBT as a bit of a tennis match between, this is a cognition. If I look at it this way, it's a bit different. And then before you know it, it's kind of like these balls bouncing between the courts. And we know that we have like I think I did some studies on it the other day. I was doing some EMDR on pain, some training and some research on a psychologist who was saying that, you know, we have up to like 70,000 thoughts per day. Now, you know, for someone who's really doing a lot of tennis matching in their head, that's exhausting. Thoughts going backwards and forwards, looking for proof. Where's the evidence to suggest that that's not the case? Whereas I kind of love mindfulness and acceptance and commitment therapy because you don't get into the battle. You just simply, oh, it's a thought. But the more that we buy into it or invest in it and start dancing and dialoguing with it, we can just simply let it be, and then we don't feed it. And then the mind goes, oh, well, I'll pick another one of the 70,000 thoughts I'll ingest in or digest in now or interact with. And it's very gentle.
The way I explain the difference between CBT and mindfulness on a very simplistic level is that CBT challenges one's thinking.
Correct.
Whereas mindfulness accepts one's thinking and moves on.
Yeah.
Yeah,
absolutely.
For me, that's a very
you nailed it.
Yeah.
And so I think that actually is really, that's a beautiful, beautiful description.
Most appropriate form of therapy for any individual within drug and alcohol services. How do you tell which patient's going to do well with CBT versus which patient's going to do well with mindfulness?
Look, my experience is some of those who are very logical, mathematical type, there's different different types of intelligences. And I sometimes when I'm working with clients, I'm looking for, you know, are they very logical in how they make sense of their world? Are they, you know, are they highly interpersonal? Are they highly reflective? You know, where's their insight, where's their capacity to kind of go inwards, and what can they tolerate? You know, sometimes when I'm looking at mindfulness, sometimes, you know, even just connecting with the breath, you know, for people who've got problems with panic or certain, you know, who are very in tune with their breathing, sometimes mindfulness, even connecting with the breath, I might not use that as an approach. I might get them just to do more of a body scan rather than tune into their breathing, because the moment they focus on their breathing, if it starts becoming irregular, you know, it can bring on certain unpleasant sensations for them. So sometimes, and some of the complaints I've had about CBT is that it's reductionist, that it's kind of robotical.
What does that mean? What does reductionist mean?
Essentially that, you know, everything that we're experiencing comes back down to a thought, that, you know, it's like a computer. And that's what I mean. People talk about it sort of being, you know, well, if I'm adding 7 + 7 in a calculator, it's going to be 14. Like, it's so predictable. It's so, and then some of the other complaints I've had is that people have spent so much time doing CBT that they've become so highly analytical in their world that there's been a loss that's come as a consequence of that. Like it's hard to describe, but they've just found that they've become so caught up in analyzing everything that they've gone very much into left brain mode, and that's become like a dominant feature for them.
So moving on to the idea of left brain mode versus right brain mode, I think one of the things that I want to emphasize about mindfulness is that there's no challenging. The role of the therapist in mindfulness is not to challenge. It's to accept current thinking and then try and create what I call the cognitive dissonance.
I think mindfulness, when I trained a lot in acceptance and commitment therapy, also for people who experience borderline personality. And some of the beautiful features of acceptance and commitment therapy is, you know, again, taking things back to a value base. So, like, you know, when we look at the thoughts and we don't attach to them, we simply notice that they're there. So for someone who might be, you know, if the thought is, I really want to score, I really want to use, can you just accept that the thought's there instead of getting into battle with it? So some of the examples that we use with mindfulness might be, you know, if you look out to the clouds in the sky, what do? They move, they never stay still. And I like to look at the human brain as almost like a bit of a movie screen that, you know, things will just keep showing up. Do we have to get into relationship with them? Do we have to have a commentary about them every 3 seconds? You know, one of the beautiful things about mindfulness is that essentially the thoughts that pop up in our head are often impersonal, but we make them personal. So I use the example, like, if people get the hiccups, I'll say to clients, do you get caught up in the story about the hiccups in your body? And they'll go, no. And I'll go, you just want someone to give you a fright or have a glass of water and get rid of them. And they'll go, yeah. But we invest in the story of our thinking. We buy, instead of just simply understanding that it's kind of neurological impulses going pop, 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 doing that, we sit there like a cat waiting to prey on something, like it's going to, this kind of thought is going to somehow give us some huge revelation, rather than just going, it's simply brain activity. Does that make sense, Fergal? Like, can you understand what I'm saying? Or does it seem a bit weird?
So maybe what word, I mean, when I use the word mindfulness, you use the word acceptance and commitment therapy. I mean, are they actually two different processes?
They dance very similarly. I think acceptance and commitment therapy has kind of been born out of mindfulness. But essentially, like, and here's an example, like if someone's got a major craving to use or something like that, if we apply the same concept to a leaf, placing that thought of it being a leaf on a stream and putting that thought there. So I'm using a bit of the work from Russ Harris, and letting that leaf go. We've changed our relationship to that thought. We've changed our relationship to it there and then. So another beautiful example that clients love is like a train pulling up at a train station. We've got a lot of baggage, we've got a lot of stuff in our head. The automatic doors open. We can put the thought on the train and we can let it go express to the city. We've made a disconnection from it. We're not again mulling around in it or immersing ourselves or percolating in the thought. We're letting it go and we're moving it through. Just like, and so another one of those 69,100 and something thought might pop in then.
Yeah. You can't have two thoughts at the same time.
Absolutely not. And the thing is,
you can replace a bad thought with a good thought.
Yeah, absolutely. And the more that you do it, the more that we disconnect it. Even when we're talking about brain change, that's actually how we change our brain. So if we're not getting caught up in the story about it, then we're not. And the example I use is like clients going through the dark tunnel in the city loop. It's repetitive, it's consistent, it's familiar. The tracks aren't going anywhere new. The train's certainly not going anywhere new. But if we just move the track ever so slightly to the left or the right, that train then gets some momentum, and it's actually no different with what's happening with our brains. So when we're caught up in the cycle of addiction, what were you going to say? That's
a great analogy, actually. Just changing the tracks can actually initiate great change. So when we started this conversation thinking about the difference between group therapy and one-on-one therapy, we don't have time to even touch on one-on-one therapy today. So perhaps we could arrange to have another chat for next time.
Absolutely.
We'll try and talk about one-on-one therapy and what can happen there. But to summarize then, we both agree that group therapy is a core part of the interventions for patients with alcohol and other drug use disorders. We've talked about psychoeducation, we've talked about CBT versus mindfulness, we've talked about peer support, we've discussed the difference between 12-step program and smart recovery, we've talked about family therapy as well. So I look forward to chatting with you next time. And perhaps we can touch on individual therapies then. Yeah,
sure. That will certainly complement understanding the group, the role of group therapy and the role of individual therapy, because they do have a dance.
Thanks, Maree. That's it for today's show. I hope you've enjoyed it, and we look forward to you joining us again soon.